Hi, everybody. This is DNH 146. We are going to be discussing Chapter 23 in the Perio book, which is topical drug delivery systems, which include the oral rinses as well as irrigation. So let's start with the oral rinses. The most common form of topical delivery of the topical antimicrobials are the oral rinses, and they're classified in two classifications: therapeutic uses and cosmetic uses. So the use is an addition to the daily hygiene control for the patient. It's an accessory to periodontal instrumentation. It's help for people with poor oral hygiene or after surgical procedures. We use it in clinic all the time as a pre-procedural rinse to reduce aerosols, as well as with dental implant maintenance. It's really only effective when we're swishing with it against supragingival bacteria because it doesn't penetrate subgingivally. So it's not for patients with periodontal disease since they don't reach subgingivally. But healthy people may discontinue the rinse if their oral conditions can be maintained without their use. But patients are going to be asking you because of commercials and social media, do I need to be using a power brush? Do I need to be using the water pick? Do I need to be using such and such type of mouth rinse? And it really all depends on whether they want to be doing it, whether they're healthy or not. You know, it's some people, more is better for them, even though they're not going to reap any of the benefits from it because they're doing a nice job and they're healthy with whatever they're doing. But antimicrobial agents should inhibit the microbial colonization on a tooth surface, as well as prevent the formation of plaque. So we can recommend some anti-plaque or anti-gingivitis agents, and it should eliminate or suppress the pathogenicity of existing plaque. So that will rely on two factors, though. First is the time that the agent stays in contact with the target site, as well as how well the agent gains access to the target site. So if you're just swishing with something for a very brief time, spitting it out, and it has no staying power, it's going to have very little effect on it. So this is what we want to know. What is the substantivity of this material or agent that they're putting in their mouth? And substantivity is the ability of the drug to absorb or bind to the intraoral surfaces, such as the teeth and the soft tissues, with subsequent release of the drug in its active form over time. So ideally, we want to be recommending a high substantivity. What is going to be used and stay in the mouth working for a long time? So you need to know about first generation and second generation of mouth rinses. The first generation rinses have antibacterial properties with very low substantivity and limited therapeutic value in reducing plaque and gingivitis. And those are typically your over-the-counter mouth rinses and mouth washes. They're just cosmetic. They're first generation versus second generation have antibacterial properties in addition to substantivity. So they're actually doing something. So let's take a look at the bisquinides. You've probably heard of this whole category in your pharmacology course, but for our purposes, we're going to concentrate on chlorhexidine gluconate. The abbreviation is CHX, okay? That's a universally known abbreviation with capital letters. And you need to know that it's positively charged. It's a positively charged ion. So after rinsing, it attracts and attaches to the negative charged bacterial cell wall, causing lysis. And lysis equals cell death or bacterial death. So this chlorhexidine actually binds to the pellicle, which inhibits the plaque formation on the teeth. Substantivity, about 30% of the drug binding to the oral tissues and the plaque or the biofilm on the teeth remains active for 8 to 12 hours after the patient rinses with it. 30% of the drug is remaining in their mouth working. So chlorhexidine is a bisquinide. It's positively charged. It causes lysis or bacterial cell death. It binds and has high substantivity, 8 to 12 hours. And it's usually in a liquid form. They've tried making toothpastes, and out of it, they have a new company came out with a new fluoride varnish, which also has chlorhexidine in it, which has a lot of promise to it. I did have a lunch and learn set up, but we had to cancel it to learn more about it. But this is oftentimes, Paradex was the first brand. Now you can get generics from it. Patient rinses or swishes for 30 seconds and then expectorates and does not rinse out afterwards. Alcohols are oftentimes added to mouth rinses. It's an inactive ingredient, so the effectiveness with chlorhexidine with alcohol and without alcohol is about the same. So, but the chlorhexidine without alcohol is a special preparation. So if you have a patient undergoing recovery or is contraindicated for alcohol mouth rinses for whatever reason, they do have a non-alcohol formula. So you want to be specific with your patients. Who are the patients that you'd be recommending chlorhexidine to? It's great for a pre-procedural mouth rinse. You can use it during as well as after periodontal debridement to reduce the plaque levels and help with the gingival inflammation. It does improve wound healing somewhat because it's killing bacteria, and it allows for better plaque control after periodontal surgery when the patient's brushing and flossing isn't able to be done or performed adequately because of the surgical site. It's also good for implant plaque control. So we normally have our patients rinsing with that twice a day for 30 seconds. Now, as we said, it's that positively charged ion of the chlorhexidine that bonds to the negative charged molecules. And the toothpaste is negatively charged as well. Fluoride, sodium lauryl sulfate, negatively charged, and that will inactivate. So it's best for the patient to rinse 30 minutes before or after toothbrushing, because we don't want the residual sodium lauryl sulfide or fluoride to inactivate the chlorhexidine and the usefulness of it. But it's very effective in reducing plaque and in scaling and root planing versus scaling and root planing alone. I think the studies have shown there's 1/4 to 1/2 millimeter more reduction in probing depths. But there are some adverse effects with chlorhexidine. It's relatively safe. One of the side effects that is more a side effect for us to deal with as hygienists is that there is a tendency for a yellow, brownish, extrinsic staining on the teeth, on the tongue, as well as restorations. But staining isn't permanent, and it can be removed during a professional prophylaxis or professional cleaning. Can't really be polished off well. It has to be scaled off. And you mostly see it on the proximal surfaces. And it's can temporarily impair the taste for the patient, as well as increase supragingival calculus formation. So think about this. If the patient's doing something to inhibit biofilm formation or to kill the plaque in their mouth, the microorganisms in their mouth, and it lasts for 8 to 10 hours, and they're doing it twice a day, that means for most of the day, they have that, whatever that is, bind to the tissues. So the impaired taste is not uncommon. So that was the chlorhexidine, the bisquinide. Let's go on to the phenolic compounds. And Listerine is a name brand of a phenolic. It uses alcohol oftentimes as a vehicle, and the mechanism of action is cell wall disruption, resulting in leakage of the intracellular components and then turning into cell lysis. Now, the original Listerine is 26.9%. I've seen board questions with this on it, so don't be surprised if you see it again. But Listerine was bad-mouthed for many, many years because of the amount of alcohol that it had. And they've got a number of different formulations now, which you'll be learning about in the fall. But this is considered a low substantivity. okay? It's strongly related to the duration of the tooth contact. You're only swishing with it for, say, 30 seconds or even a minute, then you're spitting it out, and then it's going to be diluted. So Listerine, though, even though it's been found to have an effect on the amount of bacteria in the mouth, it doesn't stay in the mouth for a whole long time. Listerine does reduce plaque, and it has been shown to reduce gingivitis. The patient rinses with it for 30 seconds. So they take a cap full of it, about 2/3 of an ounce in the morning and then once at night. And some of them can burn because you've got the essential oils in there. And the original gold, oh my gosh, that was toxic. Another compound are your quaternary ammonium compounds. And those are positively charged ions, similar to the chlorhexidine, except that after rinsing, they bind to the oral surfaces and are released more rapidly, and they lose their activity on the binding surface. So again, they don't have a whole lot of substantivity. It's only about 3 hours, and their main ingredient is CPC, cetylpridiminium. Okay, and that's the active ingredient that's in Scope and a lot of the other mouth rinses. And it has about 3 hours, so it's not bad. Whether or not it's got less alcohol in it will depend on the formulation when comparing it to the Listerine. But you want the patient to rinse very well, and again, to wait 30 minutes after brushing with the toothpaste before using the mouth rinse. Now, this can cause a little bit of staining and more calculus formation because it is having an antimicrobial effect, and there could be some mucosal ulceration or some slight sloughing of the tissue. Oxygenating agents, those are your peroxides or perborates that are mostly used for your pericoronitis and your necrotizing diseases. But hydrogen peroxide liberates oxygen, gaseous oxygen, providing a cleansing action for wounds. And it's directed at the anaerobic microorganisms. But long-term use of the 3% hydrogen peroxide has resulted in gingival inflammation. It's shown delayed tissue healing and may serve as a co-carcinogen. So that means it's compounds that are administered with low doses over a long period of time may result in an increased incidence of certain tumors. So that's exposure, though, to less than 3% has been found to be safe. So your glyoxide, for example, is an oxygenating rinse that is very soothing. And your Peroxyl also, which is a Colgate product, I believe, is, there it is, the Peroxyl it's a wintergreen foaming mint, very nice. Povidone iodine is an antibacterial and antiseptic, and it's used for the prevention of surface infections. But you can combine the iodine with hydrogen peroxide and use that as a subgingival irrigant for the reduction of those gram-negative microorganisms. Now, iodine can stain the teeth, it stains the clothing, it tastes awful. They do have a kind that doesn't stain, it's clear. So you need to use this judiciously, especially if the patient is allergic to iodine, but this is one of the best things you can irrigate with in office. Another product is from Oratec called Therasol. It has CPC in it as well as other active ingredients that are proprietary. I've used this for a number of years. It's non-staining and has the substantivity. So patients that you want to go home with and irrigate with, it tastes very pleasant, and they can irrigate with something like this. And you have to purchase through the company or through Amazon, but other things are available. Fluoride preparations for the prevention of dental caries, for the reduction of demineralization, enhancing remineralization, as well as antimicrobial properties. The best fluoride is the stannous fluoride. It's wonderful. Now, Parodontax is a GlaxoSmithKline. Crest has their gum health now. And Omni's got the Periomed, which is a solution. A lot of them have solutions that you mix with water and you swish with them. It's a great all-over fluoride preparation that does a little bit of everything. But because of the tin molecule or the tin ion. That tin ion prevents bacterial adhesion to the tooth surface. It's really great for dental hypersensitivity, but extrinsic staining can occur with extended use. So we are more apt to recommend sodium fluoride. Now the Parodontax and the Gum Health have other ingredients with it that they've done within the toothpaste to help prevent the staining. So that's not supposed to be an issue anymore. But stannous fluoride is great. And then there's pre-brushing rinses, which really act as a surfactant. They've got sodium lauryl sulfate in, which is a detergent, and it really helps just loosen up the plaque and everything. And it's intended to be a pre-brushing thing. It doesn't really reduce anything, and the studies are inconclusive as far as whether it makes brushing more effective or not. There are a number of alcohol-free mouth rinses that are available. Most of them do contain alcohol, so you want to be familiar with the alcohol-free versions. The form is either ethanol or some sort of specially denatured alcohol that's made synthetically, but alcohol can dry the tissues if it's used for a long time. We used to recommend alcohol-free mouth rinses for anybody who had a dry mouth. And Listerine, we were telling them to just stay away from because it was one of the worst things for you. But what they found was that Listerine, and this is actually evidence-based, that Listerine increased salivation for the patients with a dry mouth because it tasted so bad that the alcohol and the phenol and all the other essential oils would increase the salivary flow. Indications for alcohol-free rinses: pregnant women, patients in recovery, patients that have an extremely dry mouth, or patients that are taking metronidazole pills. Okay, they can't have any type of alcohol in their mouth. So there are a number of preparations that are available for those patients. Oral irrigation is back. Okay, it started in the 1960s as an adjunct to brushing and flossing. Studies have come out that shows that there is a reduction in supragingival plaque in gingivitis patients. It massages the gum tissues as well and gets rid of food debris that's stuck in open contact areas. And it's a great adjunct for patients who cannot floss or that have ortho. Okay, we used to think it didn't take the place of flossing, but studies are showing, you know what? It probably does, because flossing can only do so much. Water picks, those type of things it does show that it reduces gingival bleeding and pocket depths and biofilm, right? So it's a nice adjunct. There are tips that can be placed on a water pick. The one on the right side is the pick pocket that's put on a water pick, and it decreases the amount of power that the water pick has, and you can actually angle that into the subgingival area. You can send the patient home with cannulas, and this particular one on the left side is, I don't like how it's bent, but anyway, the patient is irrigating at home with whatever medicament, okay, is being recommended, because just brushing is not going to get everything. Swishing's not going to get everything. If you've got a 6 millimeter defect on the facial, say, of that mandibular anterior, you need something else to do that. But oral irrigation, like the pick pocket, you want to slowly go around. You place the tip 1 to 2 millimeters subgingivally for about 5 seconds. And with that, look at this. It can reach a 6 millimeter pocket in 90% of the time, and a 7 millimeter pocket in 64% of the time. So what else does the patient have that can do that? Flossing only gets 4 millimeters. So we need to not forget about these adjunctive things that the patient can use. But 43.4% of the clinicians perform chairside subgingival irrigation. Now, we do that because we think, we're feeling better about it. Studies have shown that the one-time irrigation that we do for our patient has no benefit for the patient unless we send them home with the ability to do something on a daily basis. But let's take a look at this hydrokinetic activity. Now, with water picks, generally they're power driven by either a main outlet or a battery, and there's two zones of hydrokinetic activity. There's an impact zone and a flushing zone. So the impact zone is when the irrigant comes in contact with the tooth surface, and then you've got the flushing zone is the deflection of the irrigant subgingivally as well as interdentally. So there's a lot going on with this water pick. And then finally it's lavage, where things are going underneath the gum tissue with the flushing zone and then coming back out of the pocket or sulcus. But it's a good way to introduce antimicrobials subgingivally. Patients find flossing difficult. They don't like to do it. Some won't do it. Sometimes if there's recession or they have a type 2 or type 3 embrasure, flossing is not going to be adequate for them. So you want to think of using an interdental brush for the patient, or a water flosser or a water pick. And they found that when paired with either manual or power toothbrushing, that the irrigation group in studies had significantly better results than brushing and flossing group in reducing gingival inflammation and bleeding. So my friends, water irrigation is back. Offices are selling them. We are giving coupons from different companies to our patients. Waterpik is a brand name, and they have a number of different models out, from very inexpensive to something with bells and whistles. They even have a new one called Fusion, which incorporates a power brush with the Waterpik device. So you're doing everything in one. There's a ViaJet, which I used to do chairside, which actually warms the medicament as well. But Oral-B's got them. Any company has them. The nice thing with the Waterpik is also they have different types of tips that you can place on them. So you can actually be doing some brushing while you are cleaning around the brackets and everything. Okay, and that's an example of something that's got a little bit of a toothbrush action, as well as a water jet device called the Plaque Seeker. So patients with severe chronic periodontitis and refractory periodontitis really require more aggressive treatment, and they might need to be referred to a periodontist. Unless you are the periodontist or working at the perio office, then anybody that we in general practice can't handle, you get our special cases. So it's important to evaluate the patient's individual needs to really match the product with the patient, right? Rule of caution: if the patient has a periodontal pocket, you want to be very cautious on what you're recommending. All right, let's take a look at some questions here. Should you recommend an oral irrigator for a patient who has a periodontal abscess? No. Which of the following substances can cause extrinsic staining? Okay, now pick the one that causes the most. Okay, chlorhexidine. Topical antimicrobial agents delivered by a rinse are effective only against supragingival bacteria. True or false? They are effective for subgingival bacterial cleansing. True, false. Which one is better, a low substantivity or a high substantivity? And again, you want something with a high substantivity. Which one of these name brands is a phenolic compound? That's the Listerine. Do you remember how much alcohol was in the original? Pulsating stream of water in an oral irrigator is better than a steady stream of water. And that's true, because you want that decompression and compression. You want that on, off, on, off, on, off to create that cavitation. You can brush your teeth right after rinsing with chlorhexidine. And you want to wait 30 minutes before you do anything. And you don't want to rinse right after you use the chlorhexidine either. Even though it's got the substantivity, it's got a lot of mint and other flavoring agents in it, You rinse right after, you squish with the chlorhexidine, you've rinsed that flavoring agent out, and you're just stuck with the taste of the chlorhexidine. Which one is sold over the counter without a prescription? Is it first generation or second generation? Man, it's the first generation. Which rinse has the highest alcohol content? Caution must be made when using handheld syringes in office irrigation, because the pressure cannot be controlled and can cause damage. So think about that handheld one, okay, the one with the cannula, right? We want to be careful. We want a gentle squirt. We don't want to go blasting anything. All right, so that is the end of this particular chapter, and I thank you for hanging in there.